we move on to the next topic. We are going to talk on, is MRI for all cranial nerve palsies is required? Dr. Rashmin Gandhi is going to speak as yes.
Thank you, Ambika. Thank you for this very kind invitation, and even bigger thank you that you've chosen my adversary, who has always been, or we have been always on the same side for last many years. He has been friend, philosopher, and guide. So today is a chance for me to compete,
Fight
maybe
him
try
out.
to compete with him. But I know that as a president and vice president of INOS, you probably have done some technical glitch here, because I'm not able to get my presentation there. All right, so Mahesh has been, and Durga have been very diplomatic. They said that, yeah, you have to do the investigation that we are discussing in few cases. You have to look at few things. You don't have to look at few things and then work for investigation. My job is going to be, I'm going to say that every single cranial nerve palsy that you see requires MRI scan. And I'm trying to argue in that way without any ambiguity. And then we'll see whether you're getting convinced or not. Yeah. So actually there is no debate. To me, I feel
We are not speaking in
that
public.
there are cases where there is no question that you require uh, neuroimaging. Let me give you an example of this. He is a 65-year-old male with vasculopathic risk factors, a clear case of third nerve palsy, uh, but when you look at his pupil, you know that he has anisocoria. So there is no debate in this case that this patient requires neuroimaging. Everybody agrees there. Very good. Now this is the second case. A third nerve palsy who recovered, has a ptosis of the left side. Recovery took place after 5 weeks. And you see on the left, you see there is a widening of pulpal fissure. And when a patient looks down, there will be a little lag. These are signs of aberrant regeneration, a clear-cut indication for neuroimaging. All right, so you are convinced that third nerve palsy, those examples, you'll do neuroimaging. One more example, patient who had a diplopia, he was told that his problem, this abduction limitation of left side, is related to his uncontrolled diabetes. But when you see his oculomotility, you see that even adduction is limited. So that means when you have multiple cranial nerve palsy, you have to neuroimage, no debate there. Another patient, 29-year-old male, type 1 diabetes, has been having diplopia for the last few weeks. And you see, patient looks to the left, everything fine. Patient looks to the right, and there is an abduction limitation of the right side. Again, no debate in this patient, though patient has vasculopathic risk factor, that you have to do MRI because of the study that Ambika, me, and others did, which was called SNAP study, was published in 2014, where we concluded, and there are other studies which corroborated us, saying anybody who is less than the age of 50, irrespective of what they have, should undergo MRI scan. So in other words, debate whether MRI is required for cranial nerve palsy is limited to very small number of scenarios like this. You say that, okay, 70-year-old male, known patient of hypertension, diabetes, and whatnot, and presents to you like this. He has a complete ptosis, and you see there is an abduction, the eye is exotropic, and when you look at the oculomotility, you'll find that patient has a complete third nerve palsy, but the pupil is not involved. So this is the scenario where you'll say, oh, 70-year-old male, vasculopathic risk factors, pupil not involved. Why don't we just wait? Because that's what the literature says, that we don't really need to do anything for these patients. However, let me run you through some of the case reports. This is the case report which was published in 2020 in Neurology, where they said pupil sparing oculomotor nerve palsy with posterior communicating artery aneurysm. It was not just one-off. This was done, there is another case report of a 56-year-old man who had a fluctuating diplopia, was diagnosed as having third nerve palsy without involvement of pupil, and was asked to observe. A few days after the diagnosis, he suffered from subarachnoid hemorrhage, secondary to aneurysm. So what it tells you is that initial period, the pupil was not involved. Now my honorable adversary, who has taught me as well, would tell you that 14% of the patients of third nerve palsy would not have pupillar involvement on presentation. So only thing you can do with these patients is just observe, call the patient back, why to undergo all this MRI and all that. But then I would say that 2008, this was from Nicholas Welpe's group, pupillary sparing and aberrant regeneration in a chronic third nerve palsy. Patient had a third nerve palsy for a few months, never had a pupillar involvement, but had posterior communicating artery aneurysm. So what you are saying here is that there is a high possibility that even if patient has a third nerve palsy, pupil not involved, he still can be harboring aneurysm which can be fatal. So that's about the third nerve palsy. What about this patient which I saw when I was at SN? Patient, vasculopathic risk factors, old age, and has a sixth nerve palsy. Now there is an abduction limitation of the left side, which is very clear. It's an isolated sixth nerve palsy. Again, we will say why to neuroimage, because these patients are likely to be secondary to ischemia. All right. Here is a case report in 2021, a series in fact, where they studied isolated sixth nerve palsy, and their conclusion was isolated sixth nerve palsy can be a first presentation of nasopharyngeal carcinoma. They followed up 66 patients, they did a retrospective analysis. And what they concluded, they said that even in patients aged more than 50 years of age, with microvascular risk factors, they all, and isolated sixth nerve palsy, they had a nasopharyngeal carcinoma, which they were harboring. Another series by Valerie Buse, Madhura Tamankar, Prem Subramanian et al., they did even larger case study, and what they concluded brain MRI and laboratory work have a role in the initial evaluation, even in the older patient with isolated acute motor neuron palsy, because in their series they found that these patients, old patient, motor neuron palsy, vasculopathic risk factors, they were still harboring something sinister in their brain. One more series by Steve Galeta's group, again they said that acute oculomotor neuropathies, they did a prospective study, and they concluded that neuroimaging as a primary modality of investigation has a role, because you are likely to miss out sinister stuff. So obviously then the question will come up, no, but we don't have MRI availability, what about cost, logistics, patient will not pay. My question would be, if patient is willing to pay, MRI is available, and the cost is not an issue, would you shy away from, with this knowledge that he can be harboring something which you cannot detect clinically, would you not go ahead and neuroimage? Now, if you say cost is an issue, well, tsunami is a once in a lifetime event, and it's extremely rare on Indian Ocean, right? But after that 2004 event, we have a complete system of tsunami warning, and at the slightest of earthquake, the whole system is activated, though it costs a lot. Why? Because what you are missing out can be really fatal. So I rest my case, ladies and gentlemen.
Thank you, Rashmin. That was a wonderful talk, and we'll see whether your friend is going to agree with that or not.